Hello, everyone. Tonight I'm going to be presenting to you my graduate project, which is on the utilization of simulation for early detection of sepsis. When you look at the description of my project sought to incorporate simulation use as a means of educating nurses and allowing facilitation of learning. Simulation use has evolved over the years, and it actually first began with pilots who were actually able to use simulation to practice more dangerous tasks such as flying blindly. Simulation allowed them to practice this, and this ability was actually later picked up by the military. For us in nursing, we were able to progress past the use of things like Rescue Annie in CPR in the 1960s, and we've actually even surpassed one of the first high fidelity Laerdal simulations we've seen with SimMan that was created in 2000. Simulation has been used in healthcare to improve the skills of healthcare workers in performing such skills as CPR, working in teams, and delivering anesthesia. Sepsis, while a well-known condition in the nursing and healthcare community as a whole, we've noticed that there are issues where it still continues to go undetected with serious mortality consequences, with up to 1,000 people impacted per 100,000 people with severe sepsis. Nurses are considered vital to detecting sepsis early, but nurses must be educated on early signs and symptoms of sepsis, the risk factors, and organized methods for detection. For my project, I actually utilized a simulation that was centered around a woman named Thelma Rogers, and the scenario, focused on her meeting the SIRS or SIRS criteria, which is the Systemic Inflammatory Response Syndrome criteria. Plus, she had the known infection of pneumonia, which for her, with two, which in her case, she actually had all four SIRS criteria, plus the known infection of pneumonia actually constituted her as being septic. This simulation was created on a patient who actually was still not yet in severe sepsis and not in septic shock, but again, yet was in the early stages of sepsis, which research has found where we would like to identify them before they actually reach severe sepsis, which has higher mortality rates. The simulation included objectives, background on the patient, vital signs, symptom assessment findings, lab values, chest x-ray with a radiology report, and teaching points. I served as the voice of the patient as well as the doctor throughout the simulation and led the debriefing, for simulation. Both a pre and post survey were completed by the learners, and we were able to move on to the project learning objectives. When we look at the objectives, we were able to actually initiate the nursing process through interviewing and completion of a focused physical assessment. We were able to analyze data collected, evaluate laboratory values, and deduct correlation to assessment findings. We wanted the learners to prioritize and organize data to effectively communicate to members of the healthcare team through the utilization of SBAR, which is situation, background, and recommendations. We wanted learners to identify signs and symptoms of sepsis and illustrate knowledge of appropriate actions through nursing interventions implemented. And also, again, for our simulations, they typically went in as a team of at least 3 or 4, 5, depending on the number of learners in the class. But again, we set out objectives for them to be able to operate as team members, to collaborate, care, and advocate to meet the needs of the patient. When we look at the teaching points, they were also a part of the simulation. In addition to the objectives, we also had teaching points that we would actually focus on during the debriefing session. Our teaching points actually focused on things such as code sepsis, which is a code at this particular hospital, in which it gives them the criteria to better identify sepsis early and actually gives them the ability to know what criteria and intervention should be implemented once a code sepsis has been put into place. The teaching points also went over more detail regarding the SIRS criteria and the inclusion of things such as a temperature of at least greater than, 101.3, with an elevated heart rate greater than 90, respiratory rate greater than 20, and a white count of at least greater than 12,000. When we look at the progression to sepsis, the sepsis criteria is typically meaning at least 2 SIRS with a source of an infection. At that point, if the person has an infection, they move past SIRS and they're now septic. When we look at how a person then progresses to severe sepsis, it's going to be everything with sepsis plus things such as organ dysfunction, lactic acidosis, significantly decreased urinary output, or abrupt changes in mental status. A person can then progress to multiple organ dysfunction syndrome, which you see represented as MODS. And then, of course, there is also septic shock, which again we found in research, most people in healthcare are excellent at identifying septic shock, but again it's a much higher mortality rate associated with septic shock, and we really feel the focus is identifying sepsis early. When we look at severe sepsis with hypotension that then cannot respond to fluid resuscitation, especially when you're seeing that drop in blood pressure, that is what's meeting the criteria for a person to be in septic shock. When we evaluate the facility, program, and target population of my graduate project, the facility, I was able to be at the Carolina Simulation Center here in Charlotte. The program is actually one that addressed advanced nurses, which is actually a nurse residency program at this facility. And my target, population were the med-surg, emergency department, and perioperative nurses. Just to speak a little bit more on Carolina Simulation Center, is actually a duly accredited facility that is actually accredited by both the American College of Surgeons as a level 1 education institute and the Society for Simulation in Healthcare, which is an accredited simulation center, and it has assessment, research, teaching, and education. When we look at the Simulation Center and all of the services that it offers, it does not just cater to or train nursing students, but it also trains undergraduate nursing students, graduate nursing students, residents, practicing nurses, and other healthcare workers. It is also not that they're just associated with a particular hospital system. They are able to actually have different and various people in the community are able to contact them, and they're able to actually take their mannequins on the road, so to speak. They also have a mobile unit where they can actually do simulations. So again, they're actually not just tied to a hospital facility, but are also here to spread simulation for the community, again, with their focus on education. When we look at what the advanced program is within the hospital system, the advanced program is actually a nurse residency program that is offered by Carolina's Medical Center for new nurses in the areas of medical surgical, emergency department, and perioperative nursing. It is actually a residency that's held over 10 months, but it incorporates things like 36 hours of professional core curriculum and a 12-hour built-in simulation time frame. They also offer formal classes, and it also has a component of preceptor training. Many patients develop sepsis after they've had surgery, and of course, after they have surgery, they end up on a med-surg unit. So again, it's appropriate for these new nurses to understand the impact they could have in a person who may develop sepsis before they are discharged home. When people are discharged, or sometimes it just progresses to the point where they actually need to seek emergency treatment. Of course, when we look at it, the emergency department nurses are actually, again, another excellent target for understanding the importance of identifying sepsis early. When we look at that additional emergency room component, we know a lot of times as the patient comes in and they're being triaged, again, knowing these early signs and symptoms would, of course, lead to earlier interventions being implemented. Again, it may cause the nurse to go ahead and see, especially if you already have a protocol for sepsis, to do things like obtain needed blood cultures. Again, with the institution of collecting blood cultures early, excuse me, you would of course be able to have the doctors initiate the appropriate antibiotics to attack the specific bacteria, as opposed to having to rely on just broad spectrum antibiotics. So the emergency department plays a very big role. As campaigns such as the Surviving Sepsis campaign have looked to institute bundles so that places specific like the emergency department has better tools for better addressing, assessing, and actually starting to initiate care for patients who are identified as septic. And of course, when we look at the role of the perioperative nurse, typically their role is to understand that without good aseptic techniques, sterile when need to be, they could actually increase a patient's likelihood of later developing sepsis. So again, we felt this was a good target population, as all of these nurses have impact and will actually have hands-on experience with patients who are septic, and again can potentially be impacted at the earliest stage as opposed as the later stages, such as severe sepsis or septic shock. When we look at the background for this project, when we look at things like the sepsis mortality rate, sepsis has a mortality rate that can be as high as 15 to 30%, and that mortality rate actually increases to almost 30 to 60% if the person has actually developed severe sepsis. The identification and creation of a process for early identification has been associated with improvements in mortality rates. When we look at some of the various studies, I actually focus on, again, the use of simulation to actually foster this education for nurses so that they can better identify signs, excuse me, and symptoms of sepsis. So there have actually been studies that have shown that simulation can be used to improve confidence, enhance teamwork, and improve communication among healthcare workers. And that confidence is actually not just with the individual in their experience, but we found that different studies have noted that that confidence has been extended to also their team members in the decisions that they make. When we look at, again, the use of simulation to foster education, not just among students, but practicing nurses, we found that those who have been involved in the simulation, per research, have viewed the simulation favorable. And that's not just the users and learners of the simulation, but also the educators who are looking to develop more learning opportunities so that we can better assist and provide education for practicing nurses so that we can improve the outcomes for patients. When we look at the process or method by which I instituted my project, again, it was based off of creation of a simulation. And again, that was a simulation that was created to include objectives, all of the information for the patient within the scenario, their vital signs, lab work. Again, a big thing with simulation would be the moulage. That was also utilized for them. Pre and post surveys that were administered to those learners that participated, and that is both the active and the passive learners. The simulation was conducted and debriefing facilitated by myself, and then survey results were then analyzed, and the simulation center uses actually SurveyMonkey, which again has the ability, once all of the data is entered, to actually run some analyzation of the simulation results for the surveys. When we look at the individual's timeline and permission aspect, The individuals that participated, beyond myself was, of course, my preceptor, who made herself readily available and was there to fully support me throughout the facilitation of both conducting the simulation and then facilitating the debriefing session that followed. I had a medical technologist that actually ran the laptop component of actually operating StimMan 3G. So he operated all of his vital signs based off of my direction, and then was able to populate labs and diagnostics per my direction, interacting with the learners. And then, of course, we had the learners who were interacting with me throughout the simulation and then in the debriefing session. The timeline for the entire simulation was more than an hour, with about 15 minutes spent in the actual hands-on interaction with SimMan 3G and speaking to myself as the patient and the doctor. And then really the learning process that occurs in simulation was in the debriefing session. And that lasted actually almost an hour itself. When we look at how the learners were allowed to interact with the mannequin, again, 15 minutes sometimes seems brief, but again, it was enough time for them to hit those objectives of implementing the nursing process, interacting with each other, doing that dynamic of SBAR with myself acting as a doctor, and then again also analyzing the data to see if they could actually identify those early signs of sepsis. Regarding permissions, I did not actually have to receive or seek any additional permissions, as this was not an active experiment. Actually, I was able to create a new educational experience for an already existing program. And so no additional permissions were required because it was more of a revamping, noting that there was a need, again, to still touch on the subject of sepsis, but look at it now from the point of not septic shock, but really focus on what evidence is showing us, which is that in healthcare, we need to do a better job of educating people on the earlier signs of symptoms of sepsis, not just severe sepsis and septic shock. When we look at the evaluation actually included, again, both information from the pre-survey and then information that we were able to evaluate from the post-survey. Here you will see an example of one of the specific SIRS questions that was on the pre and post-survey. And you see it was asking the learners which of the following patient falls within the SIRS criteria. And typically with that, they would need to at least have 2 SIRS criteria. If you look at patient A, an 18-year-old female with a productive cough, heart rate of 80, respirations 20, tip of 99.1, she does not meet the criteria. Neither her respirations, temperature, nor heart rate would meet the criteria. When we look at the 25-year-old male with an indwelling catheter, heart rate of 95, that is over 90, respirations of 24, that's over 20, and a temp of 100.6, although that does not meet the SIRS criteria, both the heart rate and respirations do meet the criteria. So in this particular question, we were looking for the answer to be B. Again, when we look at patient C, the 58-year-old post-operative female, the heart rate is right at 90, the respirations are under 20, and the temperature, again, 100.2, does not meet the criteria. And then finally, 78-year-old male with decreased level of consciousness, heart rate does not meet the criteria, nor does the respirations, although the temperature does. But again, this is a good example where with an elderly patient, again, if there's some type of infection, there may be some alterations in their level of consciousness. When we look at the actual focus of the simulation that our learners was presented with, Thelma Rogers actually met all of the SIRS criteria with a pulse of 98, respirations of 24, temperature of 101.6, and a white blood cell count of 13.5. Again, this question was actually presented to the learners on both their pre and post survey. And as a group, it was interesting to find that for Thelma Rogers, again, the subject of the simulation, when looking at how they would rate her on a scale of 1 to 10 regarding how sick she was, most of the learners only rated her as about a 5 or less. So they recognized that she had pneumonia, but with all of the other vital sign information, and again, this is even in the absence of her white count, none of them actually considered her septic prior to the debriefing. When we look at the evaluation outcome, you actually can see here, and again, this was produced by SurveyMonkey with the information that was entered on the learner's pre-survey. If you look, we said that the correct answer was B, the 25-year-old male with the indwelling catheter with the elevated heart rate and respirations. And if you look at our pre-survey, actually none of the learners recognized that this was the person who was depicting signs and symptoms of SIRS. During the simulation, the learners were able to identify that the patient had pneumonia, but actually during the actual hands-on simulation with the mannequin, were never able to make the connection to the fact that the patient was septic. During the debriefing, however, learners were able to discuss what they did well, and that was the active learners and the passive learners. And we also gave them an opportunity to discuss, again, hindsight is always 20/20, if they had an opportunity to do anything differently, would they? It was again learned that these learners were very savvy at identifying septic shock, but again, in this scenario, Ms. Rogers was still far away from septic shock, and again, they recognized that she was ill, but did not recognize the fact that she was actually septic. Learners also were not fully aware of the code shock that they had, or excuse me, code sepsis that they had at their hospital. And so we were able to actually disperse during the debriefing little badge reminders that actually outlined what the code sepsis included, that criteria, and some of those steps that they could then initiate, which the learners greatly appreciated. The debriefing highlighted the objectives that were met during the simulation, and then the learning conversation was then facilitated regarding the topics of SIRS, sepsis, severe sepsis, the multi-organ dysfunction syndrome, and septic shock. And then we also, after the debriefing, allowed the learners to then complete the post-survey. And if you look here, this is again, they were given the same question about identifying SIRS, and you can see we did have some success. So after the debriefing, at least 3 of the 8 learners were able to correctly identify which patient actually displayed SIRS symptoms. So again, during the simulation, initially, they were able to pick up on the fact that the patient was sick, coughing, and then again, eventually identified that she had pneumonia, but did not identify that she was septic. So not reflected in the, while not reflected in the ability to answer this question correctly, we actually had very dynamic conversations during the debriefing. The students were actually able to share other cases where they kind of, that light bulb moment where they realized that they had dealt questionably with patients who were septic. When we look at overall this information here about how the learners felt it went, you see that overwhelmingly we had positive reviews. So after the simulation session, learners felt like they were better able to recognize the signs and symptoms of sepsis, with at least 75% strongly agreeing that they could better recognize the signs and symptoms. And then when we look at after the simulation session, am I more confident in my role within the patient care team, you see that strongly agree was at least 87.5%, which again, the goal of this project was to definitely work on the early identification of sepsis, the utilization of simulation to foster and facilitate the education regarding sepsis, and again, to get positive feedback such as this from the learner where they do feel like they both learned and are more confident in their role and as a member of have a team. This again did not come without barriers, however, as we had things like no control over the advanced schedule. We didn't have always data regarding which learners were presenting on which day. Timing of simulation was not always optimal for the learners. And then we actually learned that some learners come with previously poor experiences with simulation from nursing school experiences. When we look at the advanced schedule is kind of preset and then worked into the simulation schedule, which is not always ideal, excuse me. There's not data provided regarding the skill mix of the learners arriving. It was felt that if we had a better knowledge of where the nurses were coming from department-wise, it could be tailored even more to the experience that they may find on their unit. And when we look at, again, the timing not being optimal, a lot of the learners, while some were coming in on their off day, a lot of the learners were coming in after working a shift, which again, their minds are kind of already taxed, not always optimal for learning. But again, we were able to have positive outcomes. And then again, speaking to the fact that some of the learners who, again, these are new nurses who are transitioning to the practice of nursing on their units. A lot of them were coming from schools where high fidelity simulations are being used, but they actually had a negative impact on them as students. And when we look at ways that we were able to actually overcome some of these barriers, again, the simulation education staff is very flexible. They do understand the time constraints, and they just come in with a great attitude to overcome the fact that it's not always the most ideal schedule. Again, they're empathetic, knowing that the learners aren't always coming in fresh, and again, make sure that it's experience that they can still gain from. A lot of this is actually accomplished through their orientation session, where the advanced learners actually come in prior to their first hands-on simulation to actually get oriented to the simulation center, how things are organized, introduced to the simulation educators, and then are given an opportunity to go into the room that they will be using for facilitation of simulation, and get a once-over explaining everything about the room as well as SimMan 3G. And prior to their tour of the facility, they have a time to introduce themselves, get to know the educators, and actually talk about any previous experiences that they have had with simulation. Literally the good, the bad, and the ugly of it. But that allows for the simulation educators to kind of talk about the differences that they may notice as they go through the rotation. One, they're no longer in school, so it's not a grade, it's not punitive. Different also from some of the student nurse perspectives of it. While there is live streaming of the simulation while it is occurring, a lot of times in nursing school it's recorded, and the active learner is then they have to review how they perform during the simulation. And some of the feedback from their school experiences, that they felt like it was more of a criticism session than more of a teaching learning moment. So the educators have the opportunity to let them know that psychological safety is one of their main focuses at the simulation center. Again, the focus is on learning, not on criticizing. It's a very non-judgmental environment, because at the end of the day, they just want the learner to leave with some new understanding, new skills, better understanding, so that they could be a more impactful and integral part of their nursing team. So the orientation, the opportunity to kind of address some of those concerns was the biggest difference I saw in changing the outcomes. I was able to see some of those learners who had reported less than favorable experiences in nursing school come away from their session at the simulation center feeling as though they were able to learn, and that it was an open environment where they did not feel judged. When we look at the project alignment with outcomes, I do feel like this project did align with the outcomes of this graduate program. I did have to do an extensive review of literature to identify not only information for the simulation, but make sure that it was something that was being discussed, something that our learners could benefit from. I was able to find information from the Mayo Foundation as well as the Institute of General Medicine. Again, information just giving me more data on sepsis. And then I was able to do additional research about where we are with sepsis. Again, a well-known condition, yet we are not excellent at lowering those numbers just yet. With that data telling me that the focus really needs to be on early detection, not detection once it's severe sepsis or septic shock. Data was collected on both the prevalence of sepsis and that utilization of simulation to foster education and facilitate learning. So I was able to find out a lot of information about the utilization of simulation, not only in student nurse education, but again, for practicing nurses and doctors as well, healthcare workers, respiratory therapists, in that healthcare actively practicing healthcare worker dynamic. I was able to take the lead role in the revision and creation of the new simulation with the purpose of educating new nurses, acting as both the lead during the simulation and conduction of the debriefing. I was able to utilize up-to-date technology for both simulation programming and the interaction with SimMan 3G during the actual simulation. In supporting the push towards better education on sepsis identification, I was able to advocate for the policy and spread of the knowledge of its presence to the new nurses, again, with handing them the badge info cards that they greatly appreciated, because again, they hadn't realized that there was a code sepsis or that there was an info section that they could clip on their badge to just kind of give them a friendly reminder of what is that SIRS criteria and does my patient lean more towards septic. The standards of regarding sepsis identification are current and in keeping with the improvements that are being advocated within both our national and now international level with projects such as the Surviving Sepsis campaign that was instituted in 2012, where we kind of realized it's not just a national issue, it's an international issue. And again, that olive branch was extended on an international level to see if, again, we could come together to come up with a better plan for treating sepsis, identification and treatment. When we look at this process, I was able to explore more ways to incorporate simulation into the graduate nurse role. Nurse anesthetists frequent the simulation center. They typically have a surgical room that's set up so that they can practice their skills as nurse anesthetists. But I was also challenged to see if there were different implications for maybe a nurse educator. We talk about the simulated patient, and it made me think about maybe the simulated learner for the nurse educator student to interact with maybe simulated learners, allowing that graduate student to be in the role of maybe a clinical educator. But also there's the opportunity with simulations to just work as an educator on the development of simulations, evaluation of simulations, similar to how we critique different research articles, maybe the process of critiquing, simulations and seeing if there are areas for improvement. And then again, that all important in participation in the debriefing process. I felt like it would be a great opportunity for a graduate nurse educator to participate in. For me, I was also afforded numerous opportunities to perform in the role of an educator, creating, programming, facilitating, and collaborating with other simulation educators to again gain just that better insight on how to facilitate without leading, and then also how to facilitate learning during the debriefing without it turning into a lecture session. When I look at the impact of this particular project on nursing education and practice, it is felt that it supports utilization of simulation for facilitation of learning in healthcare professionals, also improved identification process for sepsis. It provided helpful code sepsis reminders for the employees, and it is felt that with improved identification of sepsis, patient safety may then also be improved. So it is felt that there is an impact on not only nursing education, but then their ability to better practice, identify, and institute interventions for the benefit of their patient. If you look at this, these are my references, and thank you for listening.